This lecture will focus on cholinergic drugs. As you begin to look at the medications, remember to learn the classification and focus on the mechanism of action, as this will allow you to understand side effects, adverse effects, and therapeutic effects. Cholinergic medications are those agents that affect the activity of the cholinergic receptors. And remember back to the other lecture, cholinergic means acetylcholine. So these are dealing with acetylcholine. Okay. Most of them work directly on the cholinergic receptors by either blocking acetylcholine or mimicking acetylcholine. And while medications have therapeutic effects, there are many agents that will have a toxic effect. Think of insecticides, nicotine, those types of things that people use. There are 6 categories. We will discuss these categories and representative drugs, but remember to look for the pattern in the names to remember the information for each category. The first 2 categories that we will look at are the muscarinic agonists and the muscarinic antagonists. The muscarinic agonists, and remember back to lecture 1, what do agonists do? They mimic the effects of acetylcholine at the muscarinic receptors. The muscarinic antagonists, again go back to that first lecture, what do antagonists do? They block the effects of acetylcholine. Both categories produce their effects through direct interaction. Okay, so let's look at the muscarinic agonists, and they bind to the muscarinic receptors, thereby causing receptor activation. So the agonist will bind to the receptors and will cause it to activate. The typical drug that you will see, or the drug that is used the most, so we talk about it, is bethanechol. Its mechanism of action, okay, is direct acting. It binds to the muscarinic cholinergic receptors only, and if at a therapeutic level, it will act selectively and not have an effect on the nicotinic receptors, which is important if therapeutic. If it's toxic, it kind of does everything, and then we're going to have a problem. So its effects, it typically affects the heart, the exocrine glands, and the smooth muscles. It will decrease heart rate. It will increase secretion. It will promote contraction of smooth muscle of the lungs and GI tract, which the smooth muscle of the lungs will cause constriction. If it's used, will cause constriction of the bronchi. And for the GI, it causes the motility. And it does increase bladder emptying through the use of or through relaxation. Typically, bethanechol is only used for urinary retention. So one thing that you as the nurse who is going to be giving this medication is you need to make sure that the retention is caused by the signals being messed up, not by an actual internal obstruction. So not an enlarged prostate, not a kidney stone blocking the way. Any of those will cause problems if you give bethanechol. Alright, so when you think about adverse effects, you want to look at where it's working, what the mechanism of action is, what it's designed to do, and then think about what, if it goes awry, will cause me problems, what will kill my patient, that type of thing. So when given orally, side effects are rare. Again, look back at the pharmacological effects to see if you can determine what adverse effects your patient will see, what will kill your patient, basically. Remember, in cardiovascular, if it's decreasing the heart rate, it's going to cause hypotension. It's going to cause bradycardia. What happens if your heart rate slows down way too much? If it eventually stops, that's not a good thing. Okay? So what does this mean? As you were thinking about this, what patients should not receive this medication? When you think about cardiovascular, who would you say, maybe I don't want to give this patient to them? So what would be a good assessment maybe that you need to do before giving this medication? Starting to see why vital signs might be very important. Checking a heart rate, checking a blood pressure before you give this medicine that you're just given to help them go to the bathroom. How about GI? At the therapeutic level, it's going to increase salivation and increase acid production, but if given at higher levels, it could cause diarrhea or involuntary defecation. So what education do you think you need to tell your patients? When they first start this and we're trying to adjust levels, what might you need to talk to that patient about? What might you need to tell them they should be near? Maybe this is not the time that we go on a road trip. Maybe, while we're regulating this and getting it working, you kind of stay around the house some. For the urinary tract, they increase pressure within the urinary tract because you're going to be going more, so there's an increased pressure. That's why we would need to make sure that obstruction is not there. We don't need the enlarged prostate. We don't need kidney stones. We don't need things blocking because that's going to cause more problems. In the lungs, remember we talked back, in the lungs it deals with the smooth muscle and it causes constriction. So this is going to exacerbate asthma, okay, as it causes the bronchoconstriction. So again, what patient might you be worried about? Okay, if you saw this in their list of medications, or if this was a new medication that a doctor wanted to order, and your patient had just said that they had asthma, or that the patient has a history of asthma. Again, going back to assessment, those questions that you used to ask about the health history. This is where it all comes into play. You start looking at the health history and you go, oh, I see you have a history of asthma. They may not have had an asthma attack in the last 4 years, but they have a history of it. You might think about not putting them on this medication. Okay. Some of the other drugs that are agonists are cevimeline, pilocarpine, which you'll see pilocarpine a lot. That is typically used in the eyes, or muscarine. Toxicity can occur from too much medication or as a natural result. The sign and symptoms of toxicity are profuse salivation, bronchospasm, diarrhea, bradycardia, and hypotension. So what do you need to teach your patient? When do they need to call in? What is important about that? Treatment for this, if this goes wrong or if they have too much of the agonist, is to give them atropine and provide supportive therapy. Okay, now let's look at the muscarinic antagonists. They completely block the actions of acetylcholine. They are sometimes referred to as the anticholinergic drugs. Your typical or your representative drug is atropine. So there you go. You're using it to help combat the agonists when you give too much. That makes sense. Mechanism of action is that it blocks everything from attaching to the receptors. It does not have any effect itself, but causes the effects by putting up a blockade. So the atropine itself does not do anything other than it puts up this stop sign and says you can't go any further, and traffic now is stopped. Okay. Your pharmacological effects, as you would expect, the effects are opposite those of the antagonist. That's why atropine is used to prevent toxicity from agonists. So you're going to have increased heart rate, decreased salivation, relaxation of the bronchi, increased GI motility. There's a saying to remember anticholinergic drugs. I remember it as can't see, can't spit, can't. It rhymes with spit, but you can say it nicely as poop. Some people have have ones about it being hot and not being able to drink and those types of things. So you might find several out there. It's okay. Just if you remember that your anticholinergic drugs, they make you not be able to. They kind of dry you up if you think of it that way. They dry you up. Therapeutic uses, they're typically used pre-surgery or pre-anesthesia for surgery. It keeps the heart rate from going too low. It's used typically during eye exams and can increase a low heart rate. So you may see someone who has a really low heart rate, they may give them some atropine as a recovery drug to pull that heart rate back up. Again, go back and look at the mechanisms of actions when you're thinking about adverse effects, what effects the meds are supposed to have, then you will understand what adverse effects are. Okay, so these are drugs that dry you out, so you're going to see xerostomia, the dry mouth. They're going to have blood vision. They may be constipated. You're going to have increased ocular pressure. So with the increased intraocular pressure, who might you not give these medications to? That's what you need to be looking at. If I have a patient who comes in who has glaucoma, which is about increased pressure in the eye and is a dangerous situation, I probably don't want to give them something that's going to cause them to have increased pressure in the eye. Cholinesterase medications prevent the breakdown of acetylcholine. This has increased the total amount of acetylcholine that is available to activate receptors. There's two categories, reverse inhibitors and irreversible inhibitors. So let's first look at the reversible inhibitors. Your typical drug for this is neostigmine. Okay, neostigmine, Neostigmine. It slows down the hydrolysis reaction. Neostigmine will bind to cholinesterase instead of acetylcholine, leaving less cholinesterase available to break down acetylcholine. Therefore, more acetylcholine is available to use. So the cholinesterase kind of comes in like Pac-Man and eats up the acetylcholine. Well, your neostigmine are the ghosts that are going to keep that from happening. Okay, and you're going to have more dots in the thing to go after. Your effects, because more acetylcholine is available, that's going to decrease heart rate, cause bronchial constriction, urinary urgency, increase secretion. So going back to where we talked about the first group of drugs, you know, you had that agonist, which means that more is available. You're putting more in there, it's the same effects. More is available, same effects. Decreased heart rate, bronchial constriction, urinary urgency, increased secretions. Okay? It's typically used to treat myasthenia gravis, and we'll talk about that again a little bit more. But again, go back and look at the adverse effects. We talked about what it can do and what the adverse effects were of the other drugs. Same thing. You know, if you have a decreased heart rate, you could have bradycardia. That's going to kill you. The irreversible are your highly toxic drugs. We just kind of talk about them. They used to be used as nerve gas agents. Now they're usually only used to treat glaucoma. You're not going to see a lot of people on them just because of problems with making sure they're not toxic. So there's not much you have to know about them other than they exist. Okay. The neuromuscular blocking agents. Okay, there's two types, non-polarizing and depolarizing. The main thing to remember about both of these is that they're going to cause paralysis. But what they're not going to do is put your patient to sleep. So you don't want to use any of these drugs before doing something that's going to, cause your patient to kind of be sleepy and not realize what's happening. You would not want to be paralyzed and yet you're wide awake and know that you can't breathe and what that feeling is like. Typically they're used to provide muscle relaxation during surgery or if they're on a vent, that type of thing. And again, we'll kind of talk about those a little bit more later on. Okay. Major nursing implications for the neuroblocking agents. They're usually only given IV. You need to watch for apnea, hypertension, malignant hypothermia, muscle pain, hypokalemia. These are all kind of bad things. So again, when you go into surgery or you're on a vent and we're giving you one of these neuromuscular blocking agents, we need to be looking, are you breathing? Do you have lower blood pressure? Do you have muscle pain? Is something going on? Watch with antibiotics. That may change how well the drug interacts and may cause more problems for your patient. Okay. And so what we will do is we'll go on and I'll add into this a little bit about what the nursing implications are of the other drugs in class when we do some kind of case study stuff.